let's get going then. So within this talk, which will end with the break, we're going to be going over motivations for system science. This is a large topic. It's not a topic that I could hope to cover exhaustively, nor even deeply right now. But I hope to touch on a number of themes that will follow us through the week and that can animate some discussion. Like Elizabeth, I prefer questions when they come up rather than deferring them to the end. So if by any means you have a question related to the slides, please bring it up while I'm talking. And if required, I'll note that we'll go on and cover some aspect of that or respond to it in a more fulsome way. Within the first component of this, I'm going to be talking about particular features of health data, health observations that motivate the use of system science techniques and that complicate our understanding of these systems and our ability to navigate within them, our ability to identify interventions that are responsive within them. We'll then go on before the end of this session to talk about shared characteristics of dynamic models. Abstracting over which particular tradition we're talking about, system dynamics, agent-based modeling, discrete event modeling. We're going to be talking about generally features of dynamic models as a whole. And following the break, we'll go on to talk about particular system science methods. Health scientists have long noted that in some of the most thorny areas of health burden, there's a tremendous layering of issues and a tremendous entangling of issues that confront us while trying to understand challenges in public health and to nudge them for the better. When it comes to something like diabetes and obesity, an area where I've spent much of my professional life, we know from associations that obesity is a large-scale risk factor for diabetes. And from laboratory experiments with rat models, work that's gone on with primate models, and an understanding of human physiology, there's been an appreciation for particular causal pathways that link adiposity with, for example, beta cell depletion and with loss of beta cell mass and function, and with insulin resistance. And in recent years, there's been recent decades really, since the work of Guyton and others, there's been an appreciation for how certain complex regulatory processes play a role here. And the processes are complex. Once one's gained a certain amount of weight the first time, even if one loses weight, it's easier to regain that weight. As one tries to lose weight, your body metabolism slows down and makes it harder to lose each successive pound. There's a lot of feedbacks there. Cases where there's a change, like a loss of a bit of weight, that ripples around and pushes back against it, for example, makes it harder to lose even more weight. Or cases where you gain weight and because those adipose cells have been formed, it's really easy to regain that weight. There's also diverse actors at various levels, and some have diagrammed this out here. This from Sandra Galea's work, mapping out the food system and all of its complexity. Everything from the whole value chain associated with the food industry, but also how it links in with aspects of farming and ecosystem, and then a set of factors associated with consumer choice around labeling, et cetera, which then start interacting with individual physiological components. And the Foresight Institute has mapped out in dizzying complexity linkages between factors of different sorts and sort of diagram them out. So here we have this physiology at the center, but also tied in with individual psychology, and then these nested series of contexts, food consumption, food production, for example, social psychology, et cetera, that are germane to this. My colleague Shariki Kunaika at UPenn has mapped out layers that end up affecting individuals' patterning with respect to the dynamics of their weight based on the successive layers of context. But of course, it's not just diabetes and obesity. We see this for many, many other concerns. We see, yes, diverse actors. We see key roles of environments. The role that interpersonal factors play, even though the individual outcomes may be of greatest note, the particular likelihood of a BMI above 30, for example, or of development of certain diabetes complications. Often the interpersonal factors are seen as quite critical. Evolution of norms, attitudes, beliefs, expectation of what a real meal is, plate size and its impact on an individual's perception, yes, but shifting norms towards what a normal plate size is, a normal serving size is. And increasingly there's interest in gene by environment interaction and the shaping role of the environment. But it's not diabetes alone. We see this in heart disease and tobacco. When I first started my work in tobacco policy modeling some 17 years ago, it became very clear that it was not fundamentally a phenomenon of individual selection of their products, but it started to involve social factors. It involves addiction, yes, but also aspects of neighborhood, neighborhood availability of cigarettes and neighborhood context. It has to do with regulatory components and ability to obtain cigarettes through additional channels. There's layers of issues here as well. Economics, complex physiological regulatory processes, once again, having to do with feedbacks for addiction, the fact that getting nicotine in the system for a few early times can lead to a craving for nicotine that can sustain a buildup of habit and then lock in to a lifelong habit of smoking. Diverse actors, once again, key role of the environment, shifting norms. It is not merely accident. It's the nature of many health challenges that we face that we have these multiple contexts, multiple interacting factors, this tangled set of factors that lead to the outcomes of interest. And in many cases, this interacts with developmental schedules, critical periods in the life, dynamics of relationship, and yet outcomes over the life course. When we're dealing with situations like this, it's inescapable that we start to recognize the situation that fundamentally we're dealing with a complex of factors that cannot be considered in isolation, that need to be considered together to make sense of the patterning that we see, where in some sense the whole is greater than the sum of its parts. The level of tangling between environment and social context and these regulatory feedbacks is so strong that to consider each on its own terms is to miss a lot of the to miss the boat, really, to miss a lot of the key elements. And yes, there may be many individual components, but it's really the interactions between them that can lead to these sort of surprising emergent patterns that we see, which are not reducible to any one piece of the system. Just as we can't take a traffic jam and talk about traffic jams purely in terms of knowing about how each car works and think that if we know how each car works in isolation, it somehow accounts for traffic jams, we'd be deluding ourselves. It would be a fool's errand, right? Traffic jams have something to do with each car, but they transcend it. They're about a higher level of behavior than simply the cars in isolation. And so it is with these health challenges. The patterns that we see are quite different from what we'd expect through any one component of the system, and it's really that entangling that makes all the difference. As we'll see, because of this entangling, it's also hard not only to understand what's going on, why we see these phenomena, but to figure out how to change it. How can our interventions, how can our policies best change the situation is a vexing question when we have this set of interacting factors that interact in dizzying complexity. There's two particular challenges, though, that I'd like to highlight here, because I think they exemplify, even if they're not exhaustive, in their characterization of the challenges. One is to explain what's going on. Why do we see the sudden growth of obesity within the Canadian Aboriginal population? Our Indigenous peoples are suffering rates of diabetes in excess of 50% in population subgroups over about 55 years for women, for example. And what is it that's driving it? Does the evidence that we see support a certain hypothesis that I'm bringing to the table? Where's the situation likely to go next? Will these rates continue to rise, or are they expected to plateau? What's driving these observed patterns? And sometimes even is what I'm seeing a good or bad indication. That may surprise you, but in cases we've dealt with, for example, case reports of sexually transmitted infection, rising rates of incidence have been heralded as an alarming situation, while others have said, well, no, merely what we're doing here is merely getting better at detecting the cases that exist. Those rising rates you see are not an indication of a failing healthcare system. It's an indication of an increasingly better surveillance system, set of surveillance systems. It's a success, and it helps us make progress in terms of knowing what the real situation is. So in some cases, it's not even obvious what's going on in terms of these outcomes. Is this good or is this bad? Is it an indication of an underlying problem and an indication of a success? And since the 1700s, observers have noted certain puzzling patterns that don't seem to have obvious individual level explanation. This work from Brayley in the 1700s on deaths from bubonic plague showed this, at the time, very puzzling curve associated with deaths over time. With childhood infectious diseases, observers noted early on the sort of semi-cyclic nature of outbreaks. A semi-cyclic nature we see starting to be remanifested in areas where we have waning vaccination due to vaccine hesitancy. And these patterns, simultaneously structured but also complex, transcended geography. This is from our jurisdiction up in Canada. This is from UK and Wales, I believe. Much of the interest is in understanding patterns which transcend one particular individual. We're dealing with very high rates, for example, of demands for long-term care facilities within our health regions within Saskatchewan. And in trying to understand where that comes from, yes, we have to understand something about the patterning of dementia and frailty in the elderly, but we also need to understand something about caregiver dynamics. The fact that these individuals are being placed in care homes is not merely a reflection of their disease progress, but often of caregiver burnout or need for respite, caregivers who are just at the end of their rope with respect to taking care of an elderly loved one. And if we could provide just a bit of help to them, we might be able to forestall institutionalization for years. Trying to understand these patterns requires an understanding of this context. And similarly, caregiver and child codependence, postpartum depression and its interaction with childhood mental disorders. It's not purely one way, it's bi-directional. And if we want to understand the origins of vaccine hesitancy, we have to look for increasingly at channels of communication, such as online channels, social network channels, which provide a voice for vaccine hesitancy that hasn't been there until recently. At a spatial level, we see perplexing patterns associated with great disparities. For example, here, chlamydia within Regina, and patterns across geography having to do with sexual networks, and some aspects of spatial spread when it comes to certain conditions. A lot of what complicates our ability to reason in this case is that when we have some theory about what might be driving the situation, we're interested in trying to understand the degree to which that theory aligns with empirical observations that we see. To what degree does my theory account for this sort of sudden rise in diabetes cases among our indigenous populations? To what degree does it account for this alarming disparity we see between different regions of our province in terms of a certain outcome? And what's complicating this is that when we try to rely on informal reasoning alone, it's very hard to figure out whether these hypothesized relationships give rise to these empirical observations. It's hard to do that informally in a reliable, consistent fashion. Because often these hypothesized processes involve interactions between individuals. They often involve complex interactions with the healthcare system. They often involve demographic shifts that are very hard to reason about informally in our heads. We as humans are very good at certain things. This is not one of them. Understanding the consistent implications quantitatively of a set of processes. Moreover, often our specifications of those processes lacks the precision needed to really understand, is it likely to give rise to the sort of empirical observations that we see in observed data. So one of the challenges for these types of phenomena is that it's very difficult to go unassisted from theorizing to empirical observations that are expected. We need something to help us understand, to explicate the implications quantitatively of our theories so that we can see, does it match? Is the implication of those theories consistent with these empirical observations? And as we'll see, that's the role carried on by a model. Within this context, there's many observations of phenomenon in the form of tipping points, in the form of sudden phase changes where obesity has been almost unknown amongst a group, and then it really grows rapidly. Cases of spread of contagion over social networks, etc., which require explanation. I think I'm going to go on to the second major challenge in the light of limited time, and that is the need to intervene. Often our interests in the public health sphere are not limited to understanding what's going on, to understanding drivers, as important as they are. Often, when we seek to understand, it's often as a first step to try to figure out how best to intervene, how best to change things. And indeed, as my colleague Bobby Milstein talks about it, within this sphere and within public health in general, we're seeking to redirect the course of change. We're seeking to change things for the better. And many of the questions which come up in this area, in the health sphere, questions that I hear from our colleagues at the national, international, regional, and local levels when formulating interventions are, okay, how can I best intervene? Where best is defined variously as most effectively, or most cost effectively, or most reliably, or what have you. And often the question there is, at what stage of the process should I intervene? Should we put our resources into prevention, to secondary prevention, to primary prevention, to screening efforts, to prophylaxis, to treatment? Which target groups should we focus on? We know there's wide disparities. Should we put all our efforts into the groups suffering the largest burden, or should we spread them around? Can we invest? Can we have interventions that pay for itself by investing some upstream and some downstream, and use the downstream savings to pay for the upstream interventions? How do we best intervene? What are the particulars of a strategy? How soon should I see effects? This is a very practical thing at the political level. So our Minister of Health, they want to fix ED wait times, and for years I've been involved in a large modeling effort led by one of my former students now, one of my current students actually, to intervene in this area. And they're really interested in knowing how soon could we see effects? Will we be able to see them by 2020? We'll be able to see them by the next provincial election, right? This is a very practical matter. We don't want to declare a program dead, discontinue it before it's even had a chance to show its effects, right? We don't want to doom it, before it's had a chance to show whether or not it's successful. But this is the reality of the situation, that often we do that because we don't know how long do we have to wait for it to really make a difference with traditional techniques. How do we best scale it up? We hear this again and again, right? A program that's worked in a smaller municipality, if I want to scale it up to a large city, how do I best do that? And then there's the whole implementation science side, which I have a keen interest in and have for years contributed models to help address. How do I address the implementation science need? Make an implementation financially sustainable, scalable, sustainable from an HR perspective, a human resource perspective. So, when we're dealing with interventions, often we're interested in identifying characteristics of individuals on whom to intervene. These may be individuals who serve as bridging networks between communities. This is from TB within our province, where these represent individuals and their networks on a case contact collected basis through contact tracing. And here we've identified individuals who have high betweenness centrality. They're key bridges between communities who might reflect key individuals in which to intervene. Another display of that TB network. In other cases, we're interested in target groups with health behaviors that are that place them particularly at risk or to place others at risk. So, for example, in this work on the number of sexual partners over a 1-year period, this is from Schneeberger et al. They looked at patterning for different individuals and found that a small segment of the population has a disproportionate number of sexual partners, and those individuals in that group are simultaneously at the greatest risk of getting infected from some individual. After all, they're connected with 100. And at the same time, they're more likely, if infected, to pass it on. So these individuals might be a particularly key group at which to intervene. So when we're thinking about interventions, once again, the traditional challenge is that we're trying to consider alternative policies and ask, to what degree could we identify a policy that would yield desired outcomes? And one of the challenges here is that when we have theories about the underlying processes and these interventions being considered, we need to reason about, will this intervention, given this understanding, this working hypothesis about what's going on in the world, yield the desired outcome? And that process of going from a description of the world as it is today and these interventions to desired outcomes is not an easy process. It involves reasoning about counterfactuals and about reasoning about things that have never been observed. You may have all the data in the world about the current situation, but if you are considering interventions that have never been explored before, or portfolios of interventions, combinations of upstream and downstream interventions, being able to say, what will the outcomes look like, is not something you're going to be able to gain from those existing associations. You're going to be going into terra incognita, to unexplored territory, and you're going to need to leverage other techniques to get you there, to link these up in a way that will help establish with confidence what the desired outcomes will be. So reductionist approaches have taken us very far and will continue to take us very far. Traditional scientific approaches have predominantly explored things by taking them apart, by looking at pairwise associations, by looking at how particular pathways work in great detail. And that's advanced our understanding a great deal. But often it provides limited understanding of how the pieces fit together, how these pieces studied in isolation interact to yield the overall emergent outcomes. And particularly to understand how policies, which have never been observed before, will yield outcomes is something that is not the purview of traditional reductionist techniques. Reductionist techniques often, because they study each piece in isolation, they put limited emphasis on how the whole works together. They're extremely valuable. They will continue to be extremely valuable, but they will increasingly be used together with the sorts of techniques we'll be talking about this week. So, broadly making decisions is risky, absent insight to how these pieces affect the whole. We're dealing with situations, with systems, where the whole is greater than the sum of the parts. We need an understanding of the parts, yes, but we need an understanding of how they interact most effectively to arrive at, as my colleague Jeff McDonald talks about it, fixes that stay fixed. Okay, jumping forward a little bit here, I'd like to talk about some particular challenges that arise because of these difficulties in reasoning about observations and interpreting those observations on the one hand, and about the effects of interventions. Absent a different toolbox, a broadened toolbox, we find ourselves subject to difficulties on several accounts. One is it's very easy to misperceive the situation. I mentioned earlier a case where rising incidence rates are heralded as an underlying crisis where it may be instead a success in identification. We can misperceive a situation of declining prevalence as a success when really what it indicates is higher mortality rates among individuals with that condition that has lowered the prevalence rather than lowered incidence. It's easy to misperceive what's driving a situation without some sort of formal model of what's going on. We can easily run into policy resistance, a situation where we undertake a policy and it seems well designed, it's certainly well intentioned, but the effects ripple around and defeat or dilute the original planning, right? So health is littered with these cases, and I have many more listed if people were interested. Where development of new forms of antibiotic lead over time with excess levels of use, et cetera, to drug resistance. In the 1970s, the whole movement towards cutting cigarette tar levels was seen as a step towards lowering the burden of tobacco mortality by allowing individuals who are smoking to be exposed to less carcinogen and therefore lowering the risks of heart disease. It's now widely regarded by many tobacco experts as a negative impact, as having deleterious impact from public health because it allowed smokers to fool themselves into thinking that they could greatly lower their risk levels by switching to low tar cigarettes, smokers who would otherwise have quit. Cutting cigarette nicotine levels, an experiment undertaken based on reasoning about the physiology of nicotine addiction, is also something that was in many ways a failed experiment at its time because it led to compensatory smoking. This idea was that we could lower the nicotine levels of cigarettes and get people to smoke less. Sounds like a good idea. We'll get them less addicted. But without considering the system as a whole, what it missed is that people would smoke more cigarettes to get the same buzz, or they'd smoke them more completely, and they would expose themselves to equal levels of nicotine because they had nicotine addiction feedbacks, yes, but feedbacks driving their behavior to keep their nicotine levels at the requisite levels. And we know right now, I'm involved with this quite a bit with our big data work, that the tobacco industry has been, very cleverly and quite alarmingly seeking to undercut regulations by aggressive couponing and advertising online and targeting communities and fostering skepticism about tobacco. So policy resistance is one of these areas that we've run into a great deal traditionally in health because we've had blinders on as to the breadth of the outcomes of a given intervention. We haven't seen that broader system, we've seen just a piece of it, and we've tripped ourselves up by reasoning just about a narrow set of factors. We also may miss tipping points, cases where if we can just invest enough, it may make a qualitative difference in the outcome. This is familiar territory for those familiar with herd immunity, right? Cases where if we have a vaccination rate that achieves a high enough level, even though there may be individuals in the population who are susceptible, the population as a whole, and if you can achieve it enough, even distinct regions within that population are resistant to intrusion by infection. These tipping points, if we can just get to that point, the incidence of the associated pathogens can decline. But most importantly, I think, the phenomena that we see, absent a broadened toolbox, raises problems for 4 different common challenges that I hear from our partners in the health space, in the health policy space. Number 1, learning from experience. How do you learn from experience without an understanding of why we see these patterns and how it could have been different with different choices? For coordinating parties within different areas of the system to work together more effectively. It's not clear how my actions affect yours, etc. For planning and deciding, making plans for new interventions, and for designing a better healthcare system in terms of feedbacks involved. We risk, in short, being like the advisors of King Canute and railing against the nature of things when, in fact, our interventions inevitably lead to results that are not what we're after. So, in light of this, I'd like to talk about give a little bit of a flavor of system science and how it fits in here. I've gone through and I've cataloged a set of challenges that confront us at a very practical level within the health sphere. Challenges associated with understanding where we're at, what's going on, what the drivers are, and challenges associated with formulating interventions. How are we to address these challenges if traditional techniques don't allow us to fully grapple with them, don't allow us to address them in a firm way? Well, we make a step towards techniques that are based on the science of a whole, system science or complexity science. And an underlying basic sort of perspective here is that the patterns that we see, all those patterns of spatial positioning and network spread, and those patterns associated with very rapid rise of health burdens in certain subcommunities, that these arise from some underlying processes that are driving them. And the persistence of patterns of health disparity and ill health reflects underlying processes connecting diverse factors together. And many health problems are tightly interrelated and causally tangled that give rise to these, which makes it vexing, but thinking about it as a set of interrelated processes provides a step towards system science perspective. To truly understand why these patterns persist and why they resist efforts to address them and to lessen them, and how we can best ameliorate them, we need to reason consistently about the processes giving rise to them. The idea is that to really lower these health burdens, we need to reason in a systematic, consistent, and rigorous, and ultimately robust way about why we see these patterns. What's the nature of the underlying processes? And absent this, we risk working at cross purposes the nature of things, much like King Canute's advisors who said that he could order back the tide. It's not in the nature of things to be able to do that. It's not in the nature of things to be able to resist certain patterns if we're working at cross purposes with them. So the science of a whole is designed to help us visualize, understand, and reason about implications of our understanding about working hypotheses concerning the processes in the world, what's going on out there, and to test the consistency of those theories with evidence. It's a way of framing in a rigorous quantitative way what we think might be going on out there, and then to seeing if it holds water. Is it consistent with what we see? And if it is, my colleague Ross Hammond, who sadly couldn't be here this year because of family commitments, talks about models for theory building and for theory explication. Once you have confidence in your quantitative theory as captured by a model, you can ask, well, what would its implications be for intervention? And a central way in which we do this is through the use of these things called dynamic models, which you'll be seeing all throughout this week. And these models weave together representation of our hypotheses about the world and some capturing of evidence with respect to that. And by representing how things might work, these models can serve as tools for refining our thinking and tools for asking about counterfactual interventions and for sharing our understanding with others. So, I went through a laundry list of different factors we see in health which motivate these approaches, but I did want to provide you with one slide, and we found this useful in many past events, and I believe it's one of the slides that I may have sent Elizabeth for printing this morning. Science advising a complex systems approach, the presence of, for example, feedbacks, and the presence of interagent effects and of emergencies, patterns we see which transcend explanation with any one component. Path dependence, I didn't talk about this, but a situation where what happens early on has an effect on shaping the whole later outcomes. We think about this a lot with childhood exposure to adversity, right? We talk about critical periods in childhood. We think of the work of Barker in the UK looking at the effects of exposure to adverse childhood environments and the effect in the life course and development of chronic disease. We think about exposure to childhood trauma and its effect on development of health and social well-being. When we see cases where heterogeneity is believed by theory to have a disproportionate impact to a system, cases where we have nonlinearities, situations where, for example, we seek to combine two policies and the results of combining those policies can be very different from the sum of the gains from each policy in isolation. They may be synergistic or dinergistic. These are some science advising on complex systems approaches. Let's talk about the general features of dynamic models, reflecting on the fact that it's not until after the break you'll see two big particular types of modeling traditions and have some sense of examples of them. So, dynamic models, I had mentioned earlier, and I'll come back to this, represent sort of working hypotheses, hypothesized causal relationships regarding how diverse factors interact over time. They represent some way, we call them a dynamic hypothesis, some theory of the world. Now, in many cases, this is a best guess for what's going on in the world. In other cases, it's kind of a stylized world where we say, suppose it were this way, what would the consequences be? Sometimes it doesn't posit the world is well described by this, but rather it's a tool for helping us think through, if it were this way, what would the implications be? But we think of them as positing certain relationships between interactions and how those interactions play out over time. And these provide a way to examine system-wide consequences of changes in one or more areas of the system, where these changes might be counterfactual. They might never have been observed before. So they depict, what might be going on in the world, but do so in a way that allows us to ask what-if questions that we've never seen in the world. And these models can help us reason about system vulnerabilities, the impacts of changing system structure, and improved ways of working together. I'd like to talk in a little bit more detail about what these models include, though. And one of the first things to emphasize in this course, and it is going to be something that you may find in the course of the week, is challenging, but certainly if you decide to do further work in this area, you're going to come smack against it at some point when you do literature reviews, is these models go by all sorts of different names. Let me just rattle off a bunch of names by which they're, two of them are up there, right? So mathematical model, causal model. You've heard me talk about dynamic model. But beyond that, you'll hear simulation model, computational model. You'll hear references to particular sub-traditions, agent-based modeling, and its close tie-in with something called micro-simulation modeling. Occasionally you hear micro-population model. You'll hear system dynamics model, ODE model, ordinary differential equation model, differential equation model. You'll hear compartmental model. Those are basically referring to the same general class of types of models. You hear discrete event modeling, discrete event simulation. These are all sort of examples of what I'll put under here. And I have to be careful, because when I say computational model, that's a much broader class, but often it's used by default for this class of models, but it's a much broader class of things. So they're not all exact synonyms, and some denote subcommunities. But just be aware that if you're doing a literature search to find these sort of models, you won't be able to do a neat search and just say dynamic model and expect to get all the models out there. It's not like that at all. They go by different names, in part because they come from different fields. They're coming up from different sub-communities of discourse. A defining goal of these models, though, that unites them all is trying to understand what dynamic behavior, what behavior over time, dynamic meaning over time, results from some hypothesized causal structure, some hypothesized linkage causally between variables. Another term you'll hear from them in certain subcommunities, a mechanistic model, a model of the plumbing of a system. And what that refers to is they're mechanistic in the sense they're referring to specific pathways of effect, cause and effect, in the structure of a system. Sometimes we talk about them depicting the physics of a system. Kurt would like that. Sort of what leads to what at a more articulated level. And they're depicting this causal structure, and then they are designed to allow us to ask, okay, given that causal structure, what's the dynamic behavior that results? So given, if this is how it works, if this is how things are hitched up with one another, what would I see over time as a result of that? Okay. If I change this, what would I see differently as a result? And here, the system is hypothesized. When we say we see it over time, we see it at each step in time. It's hypothesized to be associated with a state. And using the terminology that some may be familiar with from the statistical area, but it's not unique to statistics, we talk about that state often being latent. It's often not easily directly observable. So we might be dealing with a system which is talking about the number of diabetics over time, and we have a depiction of some people who have undiagnosed diabetes in this model. We posit that there's some people out there whose diabetes status and whose pre-diabetes status is not known by the healthcare system. We can't easily count them, but we posit that in order to explain these patterns of rising diabetes rates, there's a group out there that's like that. We just don't happen to have data on them. Okay? So, in order to address, to try to elicit, to try to understand the dynamic behavior resulting from a posited structure, what relates to what. What these models do is they examine the step-by-step evolution of the system over time. So we we simulate in a way that reflects passage of time in the world, how the system evolves, the number of people who are pre-diabetic or who are diabetic, number of people who are obese, as it evolves over time. And when we have confidence enough in the system, we may ask about counterfactual situations, situations that have never been observed. Now, in the health area, this is fairly new. When I started my work 17 years ago, solely on public health, this was outre. This was seen as extremely new and a little bit out there. And there are some quarters of the health sphere where that's still considered to be the case. But increasingly it's regarded as a robust and well-founded technique. I would note that for decades we've been operating with these sort of models in other spheres. When we train people to operate power plants, when we train pilots, many of you flew to Detroit Airport, you would never want to fly with a pilot who hasn't gone through extensive training in a flight simulator before they ever fly a plane. They learn how to fly in the case of thunderstorms. They learn how to fly in the case of heavy precipitation, fly in the case of very low temperatures. And this is our all par for the course for training of pilots. Within the health sphere, we have individuals seeking to make decisions about equally complex situations who have not had recourse to similar simulations over the decades. And the thought is that they could benefit from having simulation-based support. Now, I'd like to offer a personal perspective on this. It's one that I personally find a very useful analogy. Not all modelers might necessarily agree with it, but I think it's a very powerful sort of analogy. I think of models as thinking prostheses, like a crutch, right? Like a cane. It sounds like a bizarre analogy. The point here is that prostheses, canes, crutches, etc., those boots we wear when we break a foot, these are designed to complement our limitations, right? We've got a leg that's been injured, we use crutches. We have a foot that needs to be protected, we use boots. Prostheses are designed to complement our limitations, to allow us to be fully functional despite our limitations. And I view the role of models as much the same. Models help us operate at full function despite our cognitive limitations in reasoning about the world. Models help us learn more quickly, more reliably, more robustly, and more thoroughly by helping us think through the implications of our assumptions better than we can in our head alone. Just as we use a cane to complement our limitations, we use models to complement our cognitive limitations and behave at a high level function. Now, critically here, the model helps us operate to make sense of empirical evidence more quickly. By working with a simulation, we can more quickly get down to the fact of whether our theory of the world is consistent with the empirical evidence. We can spot inconsistencies. A model won't tell us what is the case with the world, but it will more quickly allow us to spot if our theory is inconsistent with what evidence we do have. Evidence we have recourse to. Evidence from the world that otherwise we can't test whether or not it's consistent with our theory in our head alone. A model can help us say, there ain't no way your theory is compatible with this evidence. Something's got to give. Go back and figure. Go back and refigure something. And as such, a model can help us iterate more quickly in refining our thinking. So they're thinking processes. They're processes for refining our thinking so that we can align it with new evidence, we can align it with observations from the world, and more quickly advance our theorizing. Now, models, once we've developed a certain degree of confidence in them, they can be used for informing our choices. Informing our choice, well, if we were to do X versus Y, what would the trade-offs be between them. And generally they can help advance our understanding individually and collectively by allowing us to share that model with others. Please.
I was just going to say, I think it's on the syllabus. There's a wonderful piece by Josh Epstein called Why Model, and one of the things I've always liked about it is he makes a very good point, which is essentially everyone's using a model to make inference, a mental model of some kind. It's just that it's 99.9% of the time it's a model that's unexamined, and you're completely unaware of the assumptions you're making. So I think another way of thinking about what Nate's saying about thinking processes is that you're making your assumptions explicit. By putting it all out there, you can clarify what's going wrong in your own mind.
And you can, thanks, I appreciate that. You can communicate it to others in a less ambiguous way. If you and I have different mental models and each of them is trapped in our heads, it's hard for us to come to common terms. Hard for us to know exactly where do we disagree. Hard for us to be able to say exactly what the other's thinking. If we can put it into an explicit form, a form that's all laid out very precisely, it might not be guaranteed to be correct, but we can more quickly iterate to something that is closer to correct, jointly. So here, once again, we're referring to this model as a way to sort of map some theory about the world into our expectations empirically, and to allow us to do that for interventions as well. Cases where we have some theory of the world, but we also have some interventions that end up affecting that theory. So really, I think of models here as this learning tool, which is by no means to be contrasted with empirical evidence or observation. In fact, it's tightly integrated, making sense of it and helping to integrate that evidence. Where, we're refining our mental model up here, shown in the gentleman's head, and we do so by reference to formal artifacts which give results which may or may not be consistent with our understanding, and we refine this process and we refine it through observations from the world. This is our mental model, which is often fairly amorphous until we try to be precise in quantifying its implications. So Josh Epstein, and also Don Burke, so Epstein's at Hopkins, Burke is Dean of School of Public Health in Pitt, and have cataloged dozens of ways models can be useful. Within this course, we're going to emphasize a subset of those, but it's not to disenfranchise the others. But a few ways we can make explicit mental models of causality for collective refinement and discussion. Take them out of our head, put them in a public sphere under the glaring light of day, and bring to bear critique from many angles. An odd thing that I'll talk about later in the week, talk about participatory processes that you wouldn't expect. There's a lot of people who operate within a system. They may be clinicians in a hospital system. They may be public health nurses engaged in contact tracing for STIs or TB. They may be medical health officers charged with lowering the burden of obesity. Those individuals have tremendous amounts of tacit knowledge. By tacit, I mean it's not explicit. It's not something that they have written down. They may not even know that they know this thing. But when you show them a model and have them interact with the model and show them its results, that often brings out that tacit knowledge. And they'll often bring out in a way that will help refine that model. Say, no, I never have seen that. That's totally implausible. Or they'll say, we used to see that pattern, but we don't anymore. That will start a discussion about, okay, maybe the model captured things as they were earlier, but not now. Or they'll say, yes, that's in fact what we see. And many a time have I been in discussions where tacit knowledge emerged that would have been really useful if we had known about it earlier, but it only emerged because we had them interact with the model. Models can aid in learning faster and more deeply from evidence. They can more quickly spot inconsistencies between our theory and what we observe than we would have stumbled on if that model had merely remained in our heads. Because we wouldn't have known, is it consistent or is it not? We're not very good at doing that in our heads. Models can assist in the management of complex systems, complex situations. They could serve as what-if tools to identify desirable policies, policies that are cost-effective, high leverage, robust. We do a lot of work with cost-effectiveness, and if people are interested, I could show examples of models used in that context. They can evaluate benefits of restructuring a system. If we were to redesign the system like this so that, well, up in Saskatchewan, we are working with models to redesign our healthcare system in certain regards. And, you know, amongst others, we're looking at nurse practitioner-led clinics, clinics that have lower requirements for doctors, or changing the ways in which community services are delivered, et cetera. They can help us understand trends, make sense of interaction of diverse information and processes. Models can serve as kind of this clearinghouse, or this kind of overall house to house many types of lines of evidence and understanding and knowledge about a system, and can elicit that knowledge and capture it and institutionalize it. Models can help us prioritize research and data collection. They can help us spot uncertainties that matter. Not all uncertainties are the same. Some you'll find you plug into the model, it has very little impact on the outcomes you care about. Some you plug in, same level of uncertainty in proportional terms, it has a huge impact. That has caused us, for our work, to put big investments in certain types of data collection. We put our efforts into really collecting data on certain areas that the model points out probably really matter. And it's caused our healthcare system to do that with our Ministry of Health and with community-based evidence. Kurt, did you raise your hand? Okay. And finally, it helps us in this area of management understand classes of context where certain strategies are best applied. We often get that, right? Oh, they have this great strategy that worked in Vancouver. Could we bring it here? Or we had a strategy that was pilot tested in Moose Jaw. Can we bring it to Saskatchewan, to Saskatoon? And you know, can we scale up? To what degree could it be applied? How would we need to adapt it? We can do that with a model in a lower risk fashion at first before rolling out into practice. And finally, models serve as potent communication devices. Communicating our theories of the world, yes, but also communicating to policymakers outcomes of possible choices in very explicit ways, in terms that they can relate to. Okay, so a model depicts behavior of a system over time. We run a model and it sort of matches out over time the evolution of a system. There's an evolving state. The current situation changes over time. How many people are diabetic or pre-diabetic or obese or overweight or normal weight, et cetera. Those evolve over time. The number of people who have acute H1N1 or recovered from H1N1 who have not yet been exposed. Model specifies changes. Given the current situation, how is it going to change in the next little bit? And here, system behavior, as in the world, system behavior is emergent. We don't program in the results coming out of the model. We program in the rules for how the next little changes depend on the current state, and the overall outcomes of the model is an emergent feature. It's not something that we anticipate normally, and we are often surprised by it. Because like in the world, in the model, what we see coming out of the model is the interaction of many factors, and then we can't do the necessary calculations in our head. And we often are surprised by the model, and often the model surprises us in ways that gives insight into similar surprises in the world, like where we're seeing this behavior coming from. Here, in contrast to, say, a temporal regression model where we're matching some change over time in some predefined functional fashion, model behavior over time is not something we can pre-specify. It's something which comes out of our model in a way that is too complex to be able to pre-calculate. These models are what they call nonlinear in a way that prevents us from sort of pre-anticipating how it will behave over time. Okay. Because of the nonlinearity of the model, the situation in the model where the whole is greater than the sum of the parts, the situation in the model where if we combine two interventions, we often see very different outcomes than the sum of each in isolation, where if we merely double a parameter, it doesn't double the effects, compared to the baseline. We have often counterintuitive behavior that comes out of the model, and responses to portfolios of interventions are quite distinct from those interventions in effect, or in isolation. Another analogy that many students find helpful is an analogy between models and maps. And this gets to this issue of scope of a model, which is a key one we'll be hitting on a lot in coming days. Ladies and gentlemen, we've heard here that models depict sort of a working hypothesis for some way the world could work, and often it's positing how it might be working in the world. But like a map, a model represents a simplified depiction of the world. And maps are useful. If we had a map here of Ann Arbor, you wanted a map, for example, to drive through Ann Arbor to get to this class, you'd use a different map than if you wanted to cycle through Ann Arbor, or if you wanted to find appropriately walking paths through Ann Arbor. And you'd use yet a different map if you wanted to figure out why is Ann Arbor seeing brownouts or blackouts at certain times because of power problems, or why is there flooding going on in Ann Arbor because of collection of water after rainfall. All of those call for different types of maps. Each of those maps is useful. It's useful for a purpose, but they're different maps. Maps are specific to purpose. Do you get that point? Which map we use depends on our goal, our purpose. And so it is with models. So Kurt knows in my office I have a book. So in addition to teaching modeling, I more than one.
Just one book.
Yeah, right. When you get your thesis done, I'll have two. No, I have a book. I teach software engineering, software development, in addition to modeling courses, and I have a book called 75 Surefire Ways to Kill a Software Project. And I've long thought I should do that for modeling as well. The point is, with modeling, one of the surefire ways to have a modeling project fail is to say, we're going to build a model of the system. And I've heard people say that. I've even heard some experienced modelers talk about that. We're going to build a model of the immune system.
We're going to model obesity.
We're going to model obesity.
Yeah. Brilliant minds leading our generation and other generations. This is the go-to. Like, you get really excited about modeling and you want to model a phenomenon. Yeah.
We're going to model opioid epidemic. And what you have to be extremely careful about here is that becomes very similar to saying we're going to have a map of the world. All maps are wrong in the sense that they omit lots of detail, and they're useful because they omit detail, but they can still be useful. And so it is with models. George Box said it once, right? The famous statistician. He wasn't speaking about dynamic models specifically, but the point still holds. All models are wrong. Some models are useful. Models are by their nature simplifications and must be simplifications to be useful. And to be practical and to be pragmatic and to be useful, we need models that are particularly simple and that start extremely simple, and where we elaborate them in ways that reflect our learning over time about how they need to be refined to best address our purpose. So models are specific to purpose. Which details we met depend on how we want to use that model. If this is a model to catalyze to catalyze understanding between stakeholders about ways they can work together more effectively. We will use a very different model from one if we want to give quantitative outcome recommendations for detailed interventions for our Ministry of Health. We will use a very different model yet if we are interested in some rough projections early on in an outbreak of a novel infectious disease. These will be very different model structures. And even in the same domain, we will have very different model structures in exploratory modeling as opposed to very detailed policy analysis. And so models vary in completeness of what allows them to confer value. And often you don't have nearly the understanding up front you do to pick what needs to be in that model in detail until you start working with it. So you got to start extremely simple, and you got to learn from that model. And we'll come back to this issue in spades tomorrow.
I just want to.
Yeah.
We should probably make sure that they get in for the coffee.
Yep.
Before,
Yep.
I'm not sure how many.
10 minutes, yeah?
But awesome.
Yeah, yeah. So the idea here, Francis Bacon said it once. Oh, I thought I had the Bacon slide here. I'll bring home the bacon and put it in during the break. So Francis Bacon said once that one more quickly seeks truth through error than through confusion. And at first blush, that sounds like an outrageous statement. How could you be closer to truth by being in error than being confused? And the point is, fail early, fail often. That's how we'd say it now. The idea is, it's venture something, try something out, learn from it, and improve your understanding. That's how you get more quickly to truth rather than just sitting back and being confused. You try something. And so it is with models. With models, we have a way of systematically replacing confusion by learning. Putting something out there, seeing if it helps make sense of phenomena, refining it over time. And that model that we put out there can more quickly tell us if our thinking is consistent with what we see. When you have a model formulated and that model is not consistent with the evidence, there is a easy tendency some people have to view that as a failure of modeling. There's a very pernicious, I think dangerous and unfortunate stereotype of models as crystal balls. That, the perfect model is this crystal ball, like that orb that certain politicians were viewed touching in, or is it Saudi Arabia or something?
But actually, it's not just the perfect model. Any model, there's an urge to look at it like a crystal ball. Yeah, like a crystal ball. And one of the real dangers here is that when you view it that way, if a crystal ball is wrong, you say, what a useless thing. You smash it and throw it out, right? It goes out in the dumpster. Ladies and gentlemen, when a model that captures some theory fails to match observations, fails to be consistent with the evidence, it's best not viewed as a failure of a model. It's best viewed as a success of learning, because you have spotted an inconsistency between that theory and evidence from the world that would not have been captured, would not have been spotted without that model generally. Without that model to sort of say, the logical implications of this theory are this, and you say, oh, it doesn't line up. Without that model to say that you would, and modeling to say that you would have been unaware of that inconsistency. Now, it doesn't stop there, of course. Often that's a call to action for us to improve our theory. But it's important to not view it as a huge setback. In many ways, it's a huge step forward. You talk about failing forward, right? Fail early, fail often. That's how we improve things in the world, is by learning from our problems. So by improving, theorizing what's going on out there, these models help us in theory building and testing and refinement. And often even putting forward a poor initial model advances our thinking.
by allowing us to spot inconsistencies. And so there's a role for exploratory modeling, but we never use that exploratory model to give policy advice at a quantitative level. We have to realize, again, there's a purpose for this model. There's certain things that are appropriate for it, and certain things that are not. My colleague Russ Hammond, who for years has taught the course and is a major intellectual force behind the materials in this course, talks about models for theory building and contraposes that with models for theory explication. There's models that are used very early on as part of their purpose for building theory, for building up some understanding about what might be going on in the world. And generally, those models are not directly used for rigorous trade-offs and policy analysis. Often the theory isn't there. We're trying to build that theory. We're trying to build the kind of understanding of the pathways that might be operating out there in the world. But it's a very useful contribution. In other cases, the evidence base, the knowledge in the system may be sufficient to build a model for where theory is pretty well established. And we want to use the model to ask those what-if questions about practical policies, practical choices. And that's a model used for theory explication. Often we don't have a choice. Often we're in a situation where there just isn't enough evidence to pull together fully a model for theory explication yet. And we could rail, like the advisors of King Canute, against the injustice of the tide, but ultimately, we need to reflect on the fact that there may not be evidence enough to build a fully quantitative model that is fully tied down enough to be able to ask quantitative what-if questions that leverage our understanding of detailed causal pathways, and instead we contribute enormously by models for theory building. Okay. Sometimes we do have the luxury of contributing in both ways. Often we only have luxury of contributing in one way. Okay, and we're in the last 5 minutes here, in the last 2 slides. So I will just say that a common concern that we're going to come back to again and again, and that I think quite literally cannot be emphasized enough at a practical level for beginning modelers, is this concern about model scope. What phenomenon do we actually incorporate in the model? What phenomenon do we leave out of the model at the start, and then over time as we refine the model, as we enlarge it? And a key issue here is what quantities does the model generate? Does the model give rise to within it? And what quantities are represented in the model but in a pre-specified way, what we call exogenous? So endogenous things are generated by the model. It's outputting the number of diabetics over time. And other things we may put into there, for example, changes involving the what's served in school cafeterias or the availability of school exercise programs or what have you. They may be specified to the model. So endogenous things, the model giving to us, exogenous things we're specifying to it. And often choosing what's in the model between these two things is where a lot of thinking goes. And then what things are left out, consciously omitted from the model, not because they don't exist, no, but because we're not convinced yet that they are useful at this stage of our journey in building up the model. And we have them consciously put aside. We may add them in later, but for the moment, we want to start walking before we run, and we want to learn from the model before deciding whether or not they need to be added. Because there's learning going on of us from the model, and then, of course, we're shaping the model's evolution. Okay. So, key take-home messages from this part. Just a few messages. Addressing many practical challenges in public health is especially hard because they exhibit features of complex systems. They're tangled, they're multi-level. They exhibit feedbacks, nonlinearities, delays associated with them, disproportionate impact of heterogeneity, effects of context, networks, and social as well as geographic context that has a disproportionate impact on things. System science is the science of a whole that provides us with tools to represent and reason about, and indeed help manage the behavior of complex systems. And it does that in large part, although not exclusively, through dynamic models. And these models express dynamic hypotheses. They express often working hypotheses about what processes might be out there in the world that might be driving the types of things that we see. What are the processes that are going on out there? In short, what's going on out there? They help us understand this, help us understand why we see observed patterns and how interventions might affect things. Models are specific to purpose. They help us learn more quickly because of limitations we have in our heads, and they help us share our understanding with others and jointly as a community critique things that would otherwise be trapped in our heads and help us spot inconsistencies between what we think might be going on and the evidence base that's available. Make sense of that evidence base more quickly. And as we'll see within the next little bit after the break, if you don't flee, is that multiple, indeed hybrid modeling techniques are complementary. They're complementary ways of describing complex decision-making challenges and describing systems, and they each provide sort of domains where they each excel in their own sphere. And we'll see that after the break. We'll get a glimpse of the two major techniques that we'll be seeing through this course: system dynamics and agent-based modeling. Okay? So I want to thank you for your attention. It's 10:30 on the dot, and I'd invite you to partake of the refreshments over in School of Public Health 1, 4th floor.
I believe so.
And we will reconvene here in
20 minutes?
20 minutes. Is that good? Just one final note, there's a bridge over into, you don't actually have to go outside, right? There's a bridge up.
We are on the first floor.
Okay.
I'm
I don't know where the bridge goes, but it
Well, I'm going to take a field trip from the ground floor. Maybe if you want
Okay.
to explore the bridge, your team can we'll see who gets
We'll
there
see who
first.
gets there first.
Thanks. I'm actually going to explore the next few slides, so thanks very much.
Does anyone want to come with me to see if there's coffee to be found?
We can get that panel